This is a case of a colobomatis uvea with a very hard, a very leathery cataract actually, which is not seen against the red reflex. And I went, she also had microcornea, and this is how the surgery went. So initially I'm putting my 2.8 millimeter keratome incision, both the side port incisions as well. And I put a dab of viscoelastic at the colobomatis area so that the trypan blue will not escape into the vitreous from that deficiency. After that, I stain the capsule with trypan blue and express both the trypan blue and the air bubble with HPMC. Once done, I go ahead with my cystitome. And yeah, this is one of the first things that I didn't expect. See, as soon as I initiate, I realize that the zonules are extremely weak in that area. However, I am able to go ahead and continue the rhexis, but you can make out I am having a bit of difficulty. So after finishing about 3/4 of the rhexis, I decide to abandon the cystitome and take a Uthrata of forceps instead and complete the remaining part of the rhexis. And as you can see, it was easily done. You can see the folds on the capsule. That shows that the zonules are pretty deficient. That's a pretty good rhexis, and then I went ahead and I know this is going to be difficult, this cataract is going to be difficult, so I'm trying to do a very thorough hydrodissection. I know I also have to put in a CTR in this case, looking at that extensive zonular weakness inferiorly. So I'm doing hydrodissection at multiple areas. I want to make very sure that and there the pole has almost come out. Just chucking it back in, tucking it back in, and that's enough. I put in some HPMC and then check for nuclear rotation with the dialer as well. You have to do this extremely carefully because you know the zonules are already weak. Don't force it, just gently. This is more to release the cortex. I need to take out this cortex because if I put in a CTR, this is going to get entrapped and it will be very difficult later for me to take it out. And here's what I am doing. I take a Simcoe and start aspirating the loose cortex, the cortex that has been released, especially targeting the periphery. This serves a lot of purposes. One, it gives me space to put in my CTR ring. Two, it takes out the sticky cortex, and hence I'll have a much easier time later on after I've put in the CTR. And three, once I release all this, the nucleus will be much easier to handle. So here with this Simcoe itself, I am nudging and rotating the nucleus. You can see as I rotate, more and more cortex is presented to my Simcoe. Be very careful when you aspirate. Sometimes you may catch the capsule, so you have to be very careful about that. I think I have taken out more than enough cortex. It's time to put in the CTR. I make sure the CTR goes into the lens matter, so I know I am in the bag. And supporting the CTR with one Simcoe, I slowly thread my CTR into the bag. Very important to support the CTR as you are threading it into this unstable bag. When I come to the end, I engage the eyelet. See how I am pulling the CTA towards the center. Engage the eyelet, go in under the rexus and release it into the bag. Just checking whether it's gone into the bag. It has. And then I take my Phaco, take a very sharp chopper. This is not a very soft cataract. Don't be fooled. And you can see how floppy the iris is. The scleral rigidity is also giving me trouble. But I go ahead and just concentrate on the job at hand, and that is to chop this nucleus into multiple fragments. You can see the iris prolapsing through the various paracenthesis. I just ignore it, go ahead and keep chopping. I need to get 4 fragments out of this. And luckily I have managed to get the fragments. It's time to start eating them up. You have to be a little careful. You know that the bag is loose. However, the CTR is there for support. And that's easily done. It has all come out. And I come out of the eye. I then take my bimanual. Most of this cortex has been released, thankfully, and I go ahead and aspirate the cortex and the epinucleus. To be a little careful with the inferior part. However, I just nudge that tongue of cortical sheet, nudge it upwards and engage it, and I've got most of it out other than the inferior part. And I think this is a little dangerous to do it from this side, so I change hands, switch hands and take out the rest of the cortex. I then clean the posterior capsule. And leaving the irrigation inside, I fill the chamber with OVD. I don't want the chamber to suddenly collapse. And this was the other problem that I faced. I decided to put, for whatever reason, I decided to put the hydrophilic lens directly into the bag. Now this is a small bag, so I should have probably put it in the sulcus, and this is the problem I encountered. Look at the haptics, they are folded on each other, and I tried to unfold them, but it is a small bag, there's no way it's going to unfold. So finally, after trying and trying and trying, I decided that this is not going to work. I cannot leave it in the bag. I decided to pull it out of the bag. I bring out first one, Look at how the haptic is folded on itself. It's a Rayner model, very easy to manipulate it. So I brought that over the iris, and then I target the other haptic as well once I put in some OVD. To do this gently, you know that the bag is not very stable there, so that's why I'm taking a lot of care. And I've got the other haptic out also. Now I go ahead and push these haptics back into the sulcus this time. You can make out that my anterior axis is well under it. Just tucking it well, making sure it's nicely centered. And that's it. I'm not going to try and capture it in the rexus, although that's an idea. And once I'm satisfied with the position of my lens, I go ahead and aspirate all the HPMC. Keep tapping on the lens to bring out entrapped HPMC, and finally I hydrate my wounds, put in my intracameral antibiotic, and conclude my search. Thank you for watching the entire video.